Coming to the tumors of the salivary glands, they constitute a heterogeneous group of lesions of great morphologic variation. The most common site is parotid gland. Almost 2/3 of the lesions occur in parotid, but luckily most of them are benign. However, if the tumors occur in the sublingual region, they are more often malignant. In the intraoral scenario, palate is the most frequent site for minor salivary gland tumors. In the upper lip, whenever the tumors occur, they're usually benign, and lower lip tumors can be malignant. But remember, tumors in the floor of the mouth and tongue, most of them are of the malignant nature. So amongst all these tumors which I have enlisted in the classification, I'll be discussing 2 benign and 2 malignant salivary gland neoplasms. To start with, we all know the most common benign salivary gland neoplasm is a pleomorphic adenoma. This generally begins as a small quiescent nodule which can enlarge slowly over a long period of time to reach a fantastic size, as is seen in this picture. This is the lesion here, such a big lesion which is elevating the ear lobe and the pinna of the ear. But you can notice that even after the lesion is grown to such a big size, the overlying skin is absolutely intact. So this is a very important feature of this lesion, that a nodule which slowly enlarges and it becomes of a larger size, but it is surrounded, it is covered by intact skin. In case of oral tumors, generally the site which is most commonly affected is palate, and that also you can see that this is a lesion which is having this This is the lesion which is in the palate. Mostly it is covered by intact mucous membrane. However, sometimes this lesion can get ulcerated because of masticatory forces. Histopathologically, the tumor is composed of a mixture of glandular epithelium and myoepithelial cells within a mesenchyme-like background. Epithelium typically forms ducts or cystic areas containing an eosinophilic coagulum. It may also occur as cellular nests, sheets of cells or cords, or foci of keratinizing squamous cells. The most distinguishing histopathological feature by which you can identify this slide is that the epithelial component, which is surrounded by stroma with varying appearance, which is, it is myxoid, chondroid, or mucoid. This is a stroma which is myxoid in nature. You can see these areas of cystic spaces surrounded by ductal epithelial cells. This stroma is chondroid in nature. This picture is very, very peculiar. That is, areas of cystic degeneration, cystic spaces, which are having eosinophilic coagulum and surrounded by these ductal cells, which can be either in the form of sheets or in the form of cords. Very rarely in a pleomorphic adenoma one can have such keratin squams. Very rarely, and in this case the tumor may be confused with a squamous cell carcinoma, but you have to identify some element of pleomorphic adenoma somewhere in the slide to get the correct diagnosis. The second most common benign salivary gland tumor, which occurs almost exclusively in parotid gland, is Warthin's tumor. Warthin is a name of a person who has actually coined this term, but your histopathological diagnosis, the entire histopathological diagnosis comes in its synonym, that is papillary cystadenoma lymphomatosum. This is also called as Adenolymphoma, a tumor composed of glandular and often cystic structures, sometimes with a papillary cystic arrangement with characteristic bilayered epithelium. And the stroma contains variable amount of lymphoid tissue with germinal centers. What is peculiar about this Warthin's tumor is that it is almost entirely restricted to parotid gland and almost exclusively occurs in males, and there is a strong link between Warthin's tumor and cigarette smoking. Tumor may arise in salivary gland tissue entrapped within paraparotid and intraparotid lymph nodes during embryogenesis. Another theory says that it may be a delayed hypersensitivity where the lymphocytes are an immune reaction to the salivary ducts which undergo oncocytic change. A very characteristic histopathology. Macroscopically, that means when the tumor is received in the histopathology lab, it consists of a well-encapsulated mass. When we see pleomorphic adenoma, when we receive a pleomorphic adenoma, the tumor sometimes has a well-defined capsule, sometimes it has an incomplete capsule. This incomplete capsule of pleomorphic adenoma may be the cause of its recurrence. However, in Warthin's tumor, it is usually a well-encapsulated mass which comes in toto. Since it has got a lot of cystic spaces, the macroscopic specimen, we can see some chocolate brown colored fluid oozing out from that. Microscopically, it is made up of two components, the epithelial component and the lymphoid tissue. The lesion exhibits cyst formation with papillary projections into cystic spaces lined by bilayered oncocytic epithelium, and the lymphoid component may consist of normal lymphoid tissue with germinal centers. So you can see here a clinical picture. This is a swelling which is seen in the lower lobe of the parotid gland here in an elderly male, and this particular thing is the typical histopathological feature, bilayered oncocytic epithelium, cystic spaces containing fluid, and the lot of lymphocytic infiltration in the connective tissue. So when you have this bilayered epithelium along with this lymphoid element in the subjacent stroma, the histopathological diagnosis is very clear of Warthin's tumor. Coming to the malignant neoplasms, the most common malignant neoplasm in both major and minor salivary glands, that is a Mucoepidermoid Carcinoma. It's a malignant glandular epithelial neoplasm characterized by proliferation of mucus-secreting, intermediate, and epidermoid cells in varying proportions, forming cystic and solid patterns. It is the most common malignant salivary gland neoplasm in children. Commonest site is parotid, but intraorally there is a strong predilection for palate. We can see this lesion here. This is a lesion which is there in the palate. Any palatal lesions like this, one of the differential diagnoses is always a salivary gland neoplasm, either a pleomorphic adenoma or mucoepidermoid or adenoid cystic carcinoma. Here you can see one such swelling on the lateral side of the tongue. Histopathological features are also very, very characteristic for MEC. There are sheets, islands, and duct-like structures or glandular pattern with cysts of variable sizes. Mucoepidermoid carcinoma is composed of three types of cells: mucus cells, which are large with abundant foamy cytoplasm, epidermoid cells with squamoid features, and intermediate cells, which are larger than basal cells but smaller than squamous cells. And these intermediate cells are believed to be the progenitor cells for epidermoid and mucus cells. The proportions of each cell type can vary widely between tumors, and mucoepidermoid carcinoma is graded as low, intermediate, and high grade. Low grade tumors show well-defined glandular structures and prominent mucin-filled cystic spaces. There is high proportion of mucus cells. Intermediate grade tumors, there are solid areas of epidermoid cells, predominant intermediate cells, and less prominent cyst formation. High grade tumors show solidness and cores of intermediate and epidermoid cells. Cyst component is very less, mucus cells are infrequent, and what is seen is cytological atypia, neural invasion, and necrosis. That means high-grade tumors, mucoepidermoid tumors, can be confused sometimes with squamous cell carcinoma only on an H&E stain section, and therefore it may need some special stains or some markers to diagnose a high-grade mucoepidermoid carcinoma. This picture is very clearly indicative of cystic spaces surrounded by cells, and the picture below is showing you dark cells which can be either epidermoid or some of them may be intermediate, and some cells which are larger but with foamy cytoplasm, they are the mucus cells. Adenoid cystic carcinoma is another common malignancy of salivary gland. It is slow growing but aggressive neoplasm with a remarkable capacity for recurrence. and that is characterized by proliferation of ductal and myoepithelial cells in cribriform, tubular, solid, and cystic patterns. 50% of the tumors develop in minor salivary glands. Palate is the most common site. Intraoral tumors exhibit surface ulceration. Patients may present with early local pain, facial nerve paralysis in parotid tumors, fixation to deeper structures, and local invasion. Now, when I talk about facial nerve paralysis in case of adenoid cystic carcinoma, let me also make a mention of a malignant neoplasm which occurs in a benign entity. That is pleomorphic adenoma getting transformed into malignant tumors, which is called as pleomorphic adenoma. In this, the first clinical sign is facial nerve paralysis. So a slow-growing pleomorphic adenoma which has reached a large size. Suppose the patients have other manifestations such as facial nerve paralysis, you should probably suspect that a malignant change is occurring in the benign one. What is most important for adenoid cystic carcinoma is that it has a marked tendency to spread through perineural spaces. Histopathologically, as you can see in the picture, ACC is composed of ductal cells and modified myoepithelial cells. Morphologically, there are three growth patterns: cribriform, tubular, and solid. Cribriform is the most common and classic pattern. It shows islands of basaloid epithelial cells that form multiple cyst-like spaces containing mucoid material, hyalinized material. You can see these cyst-like spaces in the picture below, which gives the cribriform pattern. And these cyst-like areas of basaloid cells with cystic spaces, many times they get encircled by the hyalinized connective tissue surrounding. And that forms cylindrical patterns, and that gives a typical Swiss cheese or honeycomb appearance to this variety of adenoid cystic carcinoma. So I have briefly discussed the benign and the malignant tumors. Now a bit will go towards one autoimmune disease which is equally important, Sjogren syndrome, chronic systemic autoimmune disorder that principally involves the salivary and the lacrimal glands, resulting in xerostomia, that is dry mouth, and xerophthalmia, that is dry eyes. There are two forms of the disease which are recognized: primary Sjogren syndrome, which is also called as Zika syndrome, where there are only dry mouth and dry eyes, but there is no autoimmune disorder along with that. Secondary Sjogren syndrome, the patient manifests Zika syndrome, and in addition, there is associated autoimmune disease such as rheumatoid arthritis or SLE or polyarthritis nodosa. The picture, I have specifically put this picture of the sialographic appearance. You know that sialography is one of the diagnostic aids for Sjogren syndrome. Of course, there is a labial gland biopsy which also can be done to diagnose Sjogren syndrome. But on sialography, you can see this cherry blossom or branchless fruit-laden tree appearance, typical appearance, and that is because of extravasation of the dye through the weakened ducts and acini. So this point you have to remember with Sjogren syndrome. One last disorder of salivary glands is necrotizing sialometaplasia. It is non-neoplastic, self-limiting condition of the salivary glands. So you will ask me, why do we need to bother about it when it is self-limiting, when it is not a neoplasm? The answer lies in the point that it mimics clinically and histopathologically squamous cell carcinoma. So if you see an appearance like this, a crateriform ulcer of the palate, which simulates malignant process, maybe a clinician possibly will think that this is either a malignancy which is perforating the palate, or if it is a little bit closer to the center, you may even think of a gamma, but of course this is not in the center. So this is usually unilateral, and it is associated with history of trauma, radiation therapy, or surgery. But most of the cases are also related to vascular ischemia. So where do we come in the picture here? This vascular ischemia can also be caused because of palatal injections, local anesthetic injections. Local anesthetics have got vasoconstrictor adrenaline that can lead to vascular ischemia, and sometimes some of these patients after the palatal injection can come with such an ulcer, which you have to observe for a period of time. Let's see whether it is self-limiting, or take a biopsy and confirm it as necrotizing Sialometaplasia. That is how it is clinically important as well.